It'll be interesting. So firm hold on third line plus right now to coincide with their label by the FDA. That label has been updated with the Bruin 321 study that included second line patients. I'm not so sure that I'm jumping into using Pirto immediately second line for everyone. I think venetoclax is a great treatment for patients that have seen covalent BTK first line. And I certainly at this point in time am not wanting to use Pirto before a covalent BTK inhibitor. I believe the label still requires you to have seen a covalent BTK inhibitor at that point, but that's a question that's coming up. Will we eventually put Pirto ahead? But I need to see some more long-term data in terms of sequencing these treatments before I would feel comfortable with that. Looking, beyond Pirtobrutinib and other ways we can attack BTK. Of course, degraders are of interest, and are these going to be effective against more patients that have become resistant to, say, acalabrutinib and zanubrutinib, which we are recognizing have different mechanisms in certain ways of how they are becoming resistant to BTK with gatekeeper and kinase dead mutations that degraders seem to be more active against. So will we need to ultimately, move on from a non-covalent like Pirto to get to utilize a degrader that's more active, or will we save degraders for if Pirto doesn't work? I think at the end of the day, if we create enough viable lines of therapy for our CLL patients, most will always have an option. You'll have very few that sort of run out of options, if you will.